So the glaucoma diagnosis depends on structural and functional correlation. Regarding the structural suspicion, we have heard Dr. Medha speaking to you about the minute details, what you need to look out for to suspect glaucoma, and then how to corroborate it further by OCT by Dr. Amit Porwal. Now, once you establish a structural defect, now you need to functionally correlate that defect before you finally come to a conclusion that this patient has glaucoma. So I shall be speaking about the interpretation and functional correlation of structural defects in glaucoma with visual fields. So first, let us go on to interpret a visual field C24-2 printout specific for glaucoma. If you see, this printout is divided into 8 components. Number 1 is the type of the test, patient demographics and clinical characteristics. Number 2 are the reliability parameters that are given here. Number 3 is the Greytone chart that is useful to explain to the patient. But basically, as glaucomatologists, as ophthalmologists, zone 4 and zone 5, that is the total deviation and probability plot, and the pattern deviation probability plot are the heart of the printout. We need to look at these things first before we go on to correlate with the other things. The other thing is the global indices. Then the 7th one is the glaucoma hemifield test. And last but not the least, the raw data that helps you to come to a final conclusion. So let us go on step by step. Here we are seeing the type of the test, is C24-2. We have to understand that C signifies central, 24 signifies 24 degrees from the fixation spot, and -2 is only a notation. 24 degrees superiorly, temporally, and inferiorly. But since we expect a defect in glaucoma in the nasal step, on the nasal side, the field extends up to 30 degrees. The demographics, the patient's name and the date of birth should be correctly entered in order to retrieve. MC Mathur cannot be written as Manoj Mathur subsequently, for example. ID number, the date of the test, the start time, and the test duration, these all constitute the demographics. And the clinical characteristics. Which eye is tested, whether it is the right eye or the left eye. The stimulus size 3 is kept as a gold standard. If you change the stimulus size, you lose the advantage of StatPack analysis. The background illumination is kept constant at 31.5 apostils. The fixation monitor is the blind spot, but in patients where you suspect there is a central scotoma, the fixation diamonds can be used, and currently CETA standard is the standard strategy that we adopt for assessing the visual fields. The age interferes with the sensitivity. Every 1 decade, there is a fall of by 1.5 diopters drop. If you ask the patient the age, the patient says 35, you enter 35, whereas the real age is 50. So what the test taken by the patient is compared to the normative database of age 35 years, and then you get a diffuse suppression. That puts you in a quandary. Pupil size should be at least 3.5 millimeters for a correct assessment of visual field. It can be a little more dilated. You can adjust the lens, but generally you must avoid visual fields in a Mayo's pupil. The treatment, that the lens that you put in the holder should be slightly more, 0.5, that is to relax the accommodation. And the foveal threshold sensitivity in decibels should always be measured. Abnormal values are flagged statistically. Now, you have, when you see a printout, you know that this test belongs to this patient, where what eye is treated, and once you confirm that the test belongs to that patient, the next question that you need to answer is whether the test you are looking at is reliable or not. If it is unreliable, no point in interpreting it. So the reliability parameters are determined by the 3 components: the fixation loss rate, the false positive rate, and the false negative rate. The fixation loss rate implies that periodically, a light stimulus is projected in the area of the blind spot. If the patient sees it, that means the patient is not fixing properly. Number 2, the false positive rate. Whenever a stimulus is presented, the machine also gives a click sound. Occasionally, the machine projects a click sound but doesn't project a light stimulus. The patient sees it as seen. That means that it is a false positive, and it indicates a trigger-happy patient. And the false negative rate, contrary, the patient starts off the test well, subsequently gets fatigued, gets tired, and the machine projects a 6 decibels brighter stimulus at that point. The patient doesn't see. That constitutes a false negative test. The Greytone chart, it is a display of a map of all test points and locations with assigned interpolated values. Points are measured 6 degrees, but the values are assigned at 1 degree intervals. The interpolated values are assigned at 1 degrees interval. If you see the print out here. Olden days, the prototype machines in the late 90s, they used to carry this grid. If you see here, the brightest light stimulus, when it is perceived by the patient, that means the sensitivity is the lowest, and that is the black. Whereas the highest sensitivity value, that means the dimmest light stimulus seen by the patient is seen as total white. And in between, there are 8 different shades of gray. More better the sensitivity, brighter the Greytone chart. The heart of the printout, as I told earlier, is the total deviation and probability plot and the pattern deviation probability plot. What is a total deviation probability plot? It is nothing but it has a numeric and probability displays, represents the difference between the measured threshold for each test location and the age-corrected normal for that location. And it is abnormal if the difference is more than 5 decibels for that age. Near the edge, especially in superior hemifield, a difference of 5 decibels is considered okay. Probability plot is linked to probability value symbols. What it entirely means is, what is the mean numeric display? If suppose the expected normative database at this point is 36, patient has tested 34, that means it gives you a value of -2. If the expected value is 34, patient has tested 34, that reflects as 0. If the patient expected value is 36, patient sees 37, that is reflected as +1. So it is a numeric display, and the arithmetic mean of all this translates in your global indices for the mean deviation, where it doesn't make any sense for you to see these numbers here. So they converted these difference of sensitivity values into probability symbols from 5% to 0.5%. What is probability value for less than 5% means? It is that kind of a defect that is seen generally in about 5% of the population. And conversely, P less than 0.5 implies it is that kind of a defect that is seen in only 0.5% of the population. Hence, now when you convert these numerical values into probability symbols, you get some information as to what is the kind of field defect that you are encountering. The pattern deviation and probability plot. Like the total deviation probability plot, pattern deviation represents the difference between the adjusted threshold for each test location and the age-corrected normal for that location. What is this word adjustment? Adjustment implies general change in the least damaged portion. It removes the general component of suppression from the disease so that the focal glaucomatous defects gets projected. And what is this value? Usually it is the 7th highest value in the raw data that is considered as a cutoff. Anything about that is general suppression, and anything below that is considered focal. So now, correlation between total deviation and pattern deviation. I always give this analogy whenever I am giving this talk. Suppose if I am crossing a road, I have a fall, I sustain a hand injury. As a result of this hand injury, I go home, and by evening, I become too tired, too sick, I develop fever. When you visit me in the evening, you find me totally ill. But you are intelligent. You are saying, oh, no, this is all natakbazi he is doing. You remove the fever component and the malice component of from my disease. What stands out will be my hand injury. This is exactly what the machine does. The total deviation plot, the total depression, the total suppression of sensitivity is shown in the total deviation and probability plot. Whatever the diffuse component suppression, it can be nebula, it can be flare, it can be lenticular sclerosis, it can be vitreous degenerations, it can be chorioretinal degeneration, whatever component of diffuse suppression, when you remove that, what stands out is the pattern deviation probability plot, and the real focal glaucomatous defect is seen in the focal, in the pattern deviation plot. So if you see these 3 fields here, if Greytone chart shows diffuse suppression as corroborated in total deviation with all points being normal, that means there is no focal defect, everything is diffuse, that is most likely to be a cataract. Now, if you see this defect, inferior arcuate defect, as corroborated in total deviation with significant persistence in the same way, it is probably a case of glaucoma. If you see here, the Greytone chart shows a dense superior arcuate defect with diffuse suppression as corroborated in total deviation. When you remove the general component of suppression from this, the real focal glaucomatous defect stands out. So this is how you must corroborate by seeing the pattern deviation first, corroborate it with the total deviation, corroborate it with the Greytone chart, and then look out for the values in the raw data. Now, the global indices. As I told you earlier, the mean deviation is average, average numbers displayed in the total deviation plot. Mean deviation index indicates the overall sensitivity of the field loss. You want to give one value to how much this field is deviated from the age normal. One value, if you want to define, it is nothing but the arithmetic mean of all the values that you get in total deviation numeric plot. Now, the pattern standard deviation is a measure of amount of localized depression as compared with the age-matched controls. A low PSD indicates a smooth hill of vision, whereas a high PSD indicates a local irregularities. And the defects should be associated with the probability symbols. In the new machines, there is another parameter which is called the visual field index, or the VFI. This index expresses the visual field status as a percent of normal age-adjusted visual field. The moment you tell your patient that you may be probably having glaucoma or you have glaucoma, the first question the patient asks is what percent? So this one measure gives you an indication as to what is the probable percentage of loss for your patient. Now, the glaucoma hemifield test, it is calculated by comparing 5 zones in the upper hemifield with identical locations in the inferior hemifield after adjusting for the general height of vision. And it gives us information about the threshold value between the two halves of the field. And the 5 glaucoma hemifield tests that you get in the visual field printout are within normal limits, general reduction of sensitivity, abnormally high sensitivity, outside normal limits, and borderline. So what does it mean? If the sensitivity overall, there is no significant difference, and the sensitivity is within 99.5% of the range, it is within normal limits. If the sensitivity is such that it falls in the 0.5% of the range, it indicates a general reduction of sensitivity. And if the overall sensitivity is higher than 99.5% of the range, that is, the highest damage that you detect in the visual field is still being falling in the 99.5% of the range, that means it is hypersensitive. Whereas by glaucoma hemifield test, if the difference between the two halves is greater than that would occur in 99% of the normal population. That means if the difference between the two hemifields is such that it is seen in only 1% of the population, it is outside normal limits. And if the difference between the two hemifields is such that it is seen in 3% of the population, that means the defect is slightly less, and that constitutes your borderline. So these are all the 5 tests, glaucoma hemifield tests, that you get in the printout that helps you to diagnose glaucoma. The raw data is the display of all threshold values measured at every point. And you diagnose glaucoma by Anderson's criteria. But if the defect in your visual field satisfies these 3 criteria, then you can suspect glaucoma subject to structural correlation of optic disc. Now, if you come to reporting, if you see this report, if you want to diagnose this report in 2 sentences, the Greytone chart shows a incomplete superior arcuate defect with focal nasal step defect as corroborated in total deviation with significant persistence in the same pattern in pattern deviation that is most likely to be glaucomatous. Now, if you see moderate to severe, the 2 symmetrical field defects, superior dense arcuate defect with macular encroachment as corroborated in the deviation plots, and now total deviation in total suppression in 24-2 printout. But if you see here, the patient's vision is 612. So all these patients, whenever there is a macular encroachment, subject this patient to a 10-2 printout. This gives you the real pinhole vision that the patient is having 612 vision. Now, if you see this, the machine first tests the 4 cardinal points. The patient has not understood the test well. The 4 cardinal points are depressed. On subsequent explanation to the patient started doing the test properly. This is nothing but your learning defect. Now, if you see here, there is biarcuate suppression, but if you see subsequently, the reliability parameters, the false negatives are 57% and 59%. That means the patient has not responded to brighter stimulus at a subsequent stage. And if you look at the Greytone chart, this is the classical clover leaf pattern that you see, and that is the thing that it reflects the fatigue effect of the patient, and if the test becomes unreliable. Similarly, like this thing, when you repeat the test after 1 hour, this was the outcome. And now you see here what I was talking about, the hypersensitivity. The total deviation is much better than the pattern deviation. What does that mean? This man is superhuman. And when you correlate the raw data, you see values like 47, 48, 46, and you see the Greytone chart, there is a white scotoma. This indicates hypersensitivity the documentation. This was my old machine which I used to do fields myself 2 decades back, and I detected this. The patient had 0.6 cupping and intraocular pressures of like 22, 23. I started the patient, I diagnosed this as an inferior arcuate defect, and then patient was all right. Patient came back to me after 6 months. I repeated the fields, then I saw this. So what does it mean? Like now I realize that this patient is having an inferior quadrantanopia. So had I known the lesson that I learned first time when I diagnosed this only on the Greytone chart in my learning days as an inferior arcuate defect, had I not seen the Greytone chart, what I said, the heart of the printout is here, not here. Had I looked this 6 months back, it was a classical quadrantanopia, which I missed. So the lesson that we learn from this is any vertical separation is neurological, any horizontal separation is probably glaucomatous. So now, having understood that, I stopped looking here, I started seeing here. This is a classical superior arcuate defect, and then when you go to the Greytone chart, you see a definite vertical split. And if you see 0, 18, 0, 20, so that means there is a definite neurological split, plus there is a possible early arcuate suppression. So synopsis, give a preliminary look at the Greytone chart and the foveal threshold, corroborate it with the total deviation plot, look out for significant persistence in pattern deviation plot, confirm this defect with the PSD and CPST, and then analysis of the raw data, and then this defect should then be correlated clinically to OD change and other parameters. Only then you can diagnose this as glaucoma. Having learned how to interpret visual fields, let us now move on to the correlate, structural and functional correlation in OD. As Dr. Medha said, the first thing that you must look out in an optic disc is the size of the optic disc. This is the fovea. If you put one disc here, it overshadows this is a very large disc. What is important is not the size of the disc and the cupping. Earlier days, in 2 decades back, we used to diagnose this as glaucoma, but now we realize what is important is the health of the neuroretinal rim through which the 12 million axons are passing, and not the size of the disc and cup are interrelated. And it is a surrogate for neuroretinal rim. It is the health of the neuroretinal rim which is vital for structural diagnosis in glaucoma. So if you see this large disc with a large cup of 0.7, still the visual fields are normal. Similarly, on the other eye. Now if you see this, there is a notch here, this dipping of the vessel here. If there is a slight notch here, then that is reflecting as a focal defect in the superior nasal step. This is how you correlate. The first thing that you see is the same. If you see the field here, conversely, you are seeing a focal defect in the nasal step inferiorly. On careful evaluation of the optic disc, you see a notch here. So this is how you structurally and functionally correlate cases of glaucoma. Whereas if you see the field here, there is a dense inferior arcuate defect, and if you see the disc here, the superior rim is totally excavated and pale. Now if you see here, if you ask you to interpret this, now there is every chance if you see it through a direct ophthalmoscope, the color cupping is only about 0.5, but as Dr. Medha said, it is the dipping of the vessel that is important. That gives you a clear contour cup mapping. So if you see here, this is a near total cupping which reflects in total suppression in the visual field. In such cases, you must do a C10-2 printout to correlate with this kind of a optic disc, the near total cupping. You still in 10-2, you have some sort of visual field left, and this should be helping you in future. Now if you see this is again a possible large disc, but if you see there is a temporal pallor, such cases, if you encounter temporal pallor in optic disc, always subject those patients to visual field. You will not be surprised if you get a homonymous defects. This is the other eye. So always bitemporal pallor in optic disc, subject that patient to visual field, you may get a structural and functional correlation by way of a neurological defect, need not be glaucomatous always. So if you see this defect, the disc here, now this disc, you are seeing there is a inferior notch which is reflecting in form of a retinal nerve fiber layer defect, and if you correlate it with the OCT, now again this notch is corroborating with the inferior temporal, the thinning of the nerve fiber layer defect, which is again corroborating with the ganglion cell complex, and conversely the visual field is giving you a focal defect in the superior nasal step. This is exact structural and functional correlation by way of optic disc, by way of OCT corroboration, and then functional correlation in the visual field of an early case of glaucoma. Now again, if you see this disc here, you correlate with the OCT, you see the inferior thinning of the neuroretinal rim here, and the ganglion complex is corroborating, and the central corneal thickness is again showing a slightly thinner thing, and then that gives you a superior arcuate defect on the visual field. And now, in this disc, again, if you see, when you correlate with the OCT, there is diffuse retinal nerve thinning, and the ganglion cell complex is again involved totally. The visual fields are compressed. If you see this disc at the outset looks more like a normal thing, but the contour cupping is the thing. It is how you see that contour cup, how you mark out the contour cup, and then you corroborate that with the OCT, and then the visual field, that is most important. And now some interesting cases. Here if you see the IOP is 24 and 23, the CCT is like this. If you see here, there is excavation, not exactly, the sharp edges on the nasal side, not exactly. In glaucoma, generally you expect something on the temporal side, but here there is something on the nasal side which is sharp edges. If you corroborate with the OCT, it is perfectly showing, but it is in the superior nasal. Had it been superior temporal, we would have certainly tried to treat the patient, but I leave it to you with a pressure of 24, with sharp edges, with OCT corroboration, whether the visual field is normal, whether we would like to bring down the pressure to a certain extent, or would you like to follow up this patient. Again, a similar situation with this kind of a thing, the visual fields being normal. If you see the ganglion cell complex on both the eyes, subject to other pathological conditions, if there is none, if the ganglion cell complex is involved, then this study shows that 10% of these patients are likely to progress to frank glaucoma. So it is up to you to decide whether you want to treat it or not. Whereas if you see this disc here, like here the neuroretinal ring is somewhat okay, but here I had a definite suspicion there is something wrong. So when I did an OCT, OCT is absolutely normal. And visual fields, because I was not happy, I thought something is abnormal, I did the visual fields subsequently. Always the visual fields are normal, and I'm happy to maintain this pressure on the intraocular pressure of 23. You need not treat such patients. So this is how structural and functional correlation by optic disc, by OCT, and functional correlation helps you to come to a conclusion whether you need to treat any patient on individual case basis or not. Now, if you see this case, a 54-year-old with anterior segment normal, half ACT, and pressures of 19 and 14, this gave me a suspicion. Always an asymmetry between the two eyes. Why are the intraocular pressures 19 and 14 and open angles, and this was the kind of disc that I saw. Then I subjected the patient to visual field. Because of intraocular pressure asymmetry, I found the visual field normal. Then I did an OCT. In OCT, what did I see? In the right eye, 19 pressure, other eye was 14. In 19 pressure, there was a superior temporal thinning. Then I thought, oh, this is an asymmetry. I sent the patient, I asked him to come back after 3 months. When the patient returned after 3 months, I was wise enough. Was in my early days when of my tryst with the OCT. Then I knew about the GCC complex. So I wanted to take a printout with the GCC complex. I did it complimentary for the patient after 3 months. And on the second setting, again, then because of that superior temporal thing, I started seeing some sort of a new nerve fiber layer defect dropout here because there was a definite superior temporal thing, and I suspected that there is something going to be there. So when I repeated the OCT, I found this. Where is the superior temporal defect that was detected earlier? There is nothing. Now, what does it mean? The left eye is totally normal. I had a superior defect, and the GCC complex is also normal. Then I had a careful lookout of the two printouts, the earlier one, and this was the thing. Here, the OCT was absolutely normal. If you see here, what is it? It is the disc is absolutely centered. Whereas if you see here, I got the superior temporal defect only because the disc is decentered. Instead of checking the thickness here, the thickness is checked here. So OCT in itself is a good machine. OCT in itself, you cannot say it is normal, you need not. It is the person behind the machine. It is proper centering. It is the person behind the machine that is important. You cannot say OCT is useless. Machines are machines. It is the person behind the machine. How you do the test, how you interpret the test is most important. So thank you for your patient hearing.